I'm going to be talking about IBD special populations, pregnancy and elderly. And then after the lunch break, I'll be giving another talk about medical therapy more specifically. So here's just a little bit about me. I have an interest in women's health, which is one of the things that we'll be focusing on here. And so we're going to first talk about pregnancy and preconception counseling. So this is a publication that came out in 2019 and was a statement from the IBD Parenthood Project Working Group, which was the AGA in conjunction with the OB-GYN Society, coming out with some guidelines for preconception counseling and care during pregnancy. We are expecting publication of some new international consensus guidelines for preconception counseling and pregnancy in the coming months. I understand it's been submitted and is in revision, so there will be some new publications to provide guidance soon, and I'm including some of those recommendations in the talk. But this is still a good summary to reference in the interim. The IBD Parenthood Project has a patient-facing website that I find very helpful. This is the website for it, ibdparenthoodproject.org, and it just goes over for patients a lot of the concepts that we talk about in clinic, like why do you need to see a maternal fetal medicine OB, and what are the questions you should be asking? What are the things you need to know? So it's kind of a nice summary for them to reference after your visit and after you've given them some of this information. So this is kind of an overview of how we think about preconception counseling in IBD. We know that a lot of our patients are diagnosed during their childbearing years or before their childbearing years. So this is a really important thing for us to talk with them about. And preconception counseling really includes a lot of different things. First and foremost, it includes disease management. And as always, making sure our patients are in a stable steroid-free remission. We really want before conception for that to be stable, that it's been at least 3 months, that they just didn't like finish their prednisone taper yesterday. And we want to make sure that this is going to work. They're going to stay well on it. We want to really confirm that remission with some sort of objective marker, whether it's a calprotectin or an ultrasound or an MRI or a scope, wherever, depending on where their disease is located. In terms of fertility, we want to think about their risk factors for decreased fertility and when they need referral. We'll talk a little bit more about that later. We want to think about whether anyone needs to be involved at this point, whether it's our dietitians, maternal fetal medicine specialist, a colorectal surgeon. And then, of course, we need to think about their medications. Are their medications optimized? Are they safe to continue during pregnancy? Is there a way we can to make the regimen safer or more effective for them? And then finally, are they up to date on their healthcare maintenance? Because obviously during pregnancy, it's not going to be a time you're going to do an elective colonoscopy for colon cancer surveillance. And you want to make sure that these other things like tapering off drugs and alcohol and tobacco that may be harmful for a pregnancy are done beforehand. So then to get a little bit more into the nitty gritty of these, we really know that preconception counseling can be effective in decreasing disease relapse and can help prevent low birth weight births. It really is helpful in medication adherence and smoking cessation, because I think a patient's tendency is to panic, right? They don't know necessarily if their medication is safe or not. They don't, and so their impulse is to just stop it, which in most cases is the wrong thing to do, because them being well and in a stable remission is actually the most important thing they can do for a healthy pregnancy. So you really want to make sure that you've addressed it with them before, that you've answered all questions, that they have a comfort level about what the plan's going to be, because otherwise they're kind of left on their own to make a plan without the consultation from you. So genetic risk of IBD in offspring is a question a lot of patients have. They're very worried about passing on their disease to their children, and will they be giving this to their children? There used to be this concept in IBD that there was this chosen childlessness amongst IBD patients because they were really concerned about passing on disease, and they were really concerned they weren't going to be well enough to care for a child. I think that has changed over time as we get more information about this out and we have more effective therapies, that people are feeling more confident. But really, we know that genetic risk overall in IBD is only one piece of the puzzle, and it increases the risk, but it isn't the whole story. So the risk of an offspring developing Crohn's in a mom with Crohn's is 2.7%. The risk of an offspring developing ulcerative colitis if a mom has ulcerative colitis is 1.6%. So that's really quite low. So small studies have suggested when both parents have IBD, the risk might be higher. So fertility in IBD. Fertility rates in IBD patients for patients that have not had surgery involving the pelvis and are in a stable remission should really be the same as the general population. We do think that active inflammation might decrease fertility, and that surgery with a pelvic dissection, such as removing the rectum or proctectomy or making a J pouch, might decrease fertility because it can cause scarring in that pelvic area near the fallopian tubes. IBD medications do not affect assisted reproductive technology, such as like intrauterine insemination or in vitro fertilization. But for reasons that we don't understand, IVF or assisted reproductive technologies are less effective in IBD patients, and no one really has come up with a good explanation for that. Because there are these factors in our IBD patients, all IBD patients should be referred for an infertility evaluation and treatment after 6 months of attempting to conceive, regardless of what their age is, which is different than the recommendations for the general population, which recommend referral for infertility evaluation depending on how old the patient is. Disease activity really is a key factor in affecting birth outcomes. We know that if mom has active inflammation and active disease, then that is a risk factor for the pregnancy. And so the priority is really having mom be well on a safe medication, and really that's how we have a safe pregnancy. So this is just one study showing this. I'll show you that there have been many studies showing the same thing. This is a Danish nationwide cohort of 219 pregnancies on anti-TNF therapy. They found that moderate to severe disease activity had an odds ratio for preterm birth of 3.6. And amongst women that had ulcerative colitis and active disease, 19.5% had low birth weight and 29% had preterm delivery. So really the greatest risk to a pregnancy is active disease. So this just shows that there have been lots of studies that show this, that it's active disease during pregnancy that carries the higher risk of low birth weight and small for gestational age babies. And that's what we really need to avoid. This is a newer recommendation that will be in these upcoming consensus guidelines. We know that patients with chronic inflammatory conditions have a higher risk of preeclampsia. And in these new guidelines is going to be the recommendation for low dose aspirin between 12 to 16 weeks of gestation to decrease preeclampsia risk. As you know, in our IBD patients, we're often recommending avoidance of NSAIDs. And so there is a reluctance and a concern amongst OBs to put an IBD patient on an NSAID such as aspirin. I've gotten a lot of questions from OBs about this. It is safe. Aspirin use in this setting for IBD patients has been studied and is safe to do. And the risk benefit of preventing preeclampsia versus being on this low dose NSAID in a patient that should be in a stable remission is in favor of them being on the aspirin. Initially in the US, they were using 81 milligrams because I think the study dose in Europe was 150, which we don't have in the US, but I believe now they've actually shifted to using 2 baby aspirins or 162 milligrams. So when my colleagues in OB are asking me if it's okay, I say yes, and I'm actually proactively telling my IBD patients, talk to your OB about being on aspirin after 12 weeks for preeclampsia prevention because we know that they are at increased risk. Okay, so now turning to medication safety. Like I was saying, staying in remission is a priority. So we want to make sure that the medication that we have them on to maintain that remission is one that's safe for the pregnancy. Um, so medications like valsalazide, low risk, continue. Mesalamine, low risk, continue. Sulfasalazine, you just need to make sure they're on a bit higher folate supplementation. And if it's a male who wishes to have his partner become pregnant, they should switch to an alternative medication because it can lead to oligospermia. Methotrexate is teratogenic, so it needs to be stopped. This is one of the few medications that's an absolute no. It needs to be stopped at least 3 months before conception. And this is something important to talk about all female patients that could become pregnant when they're put on methotrexate, that you cannot become pregnant on this medication. If you want to become pregnant, let me know. We'll need to stop the medication. So always a key thing to go over with any patient on the medication. Azathioprine or 6-MP. So more recently, there has been data come out that there's an increased risk of intrahepatic cholestasis of pregnancy with a different shifting of the metabolites. We know that the therapeutic metabolite of azathioprine is 6 TG, and the more harmful metabolite is 6 MMP. During pregnancy, there seems to be more shunting towards that harmful metabolite, and they have found preliminarily that split dosing, so if they're on 100 milligrams, doing 50 twice a day instead of 100 once a day, is helpful. A lot of patients nowadays are on azathioprine or 6-MP in combination, in particular with an anti-TNF therapy like Remicade or Humira. And we know that the combination might have an increased infection risk in the baby. So overall, the recommendation is if this is a patient that has been stably well on azathioprine or 6-MP, and that's what's kept them in remission, you can continue it. You may want to split the dosing. And if they're on combination therapy with an anti-TNF, before they conceive, you could consider checking the drug level, and if they're stable, considering stopping the azathioprine or 6-MP. But remember that the anti-TNF drug level could fall by as much as 50%. So you're going to want to do that ahead of time and recheck the drug level to really make sure that everything is stable before pregnancy. Budesonide, there isn't a lot of data, but small studies and asthma data suggest that it's low risk. It's okay to use if needed. Prednisone, as always, we want to use the lowest amount for the lowest amount of time needed. So it can lead to things like gestational diabetes, premature rupture of membranes, preterm birth, infant infections. So if you need it for a flare, you should treat it. You should not undertreat pregnant patients because there is this priority to keep the inflammation under control, but of course, try to avoid it if you can. Oops, I went the wrong way. I don't know what happened there. Oh. I think that was a repeated slide for some reason. Okay, so steroids in pregnancy. Here's a little bit more detail about it. So there's older data that reported an increased risk of cleft lip or cleft palate in the first trimester. But more recently, there's been a more large-scale Danish study of over 50,000 patients in pregnancies exposed to steroids in the first trimester, and they did not find elevated risk of these deformities. It's always very hard to separate what's a steroid effect and what's an effective active IBD activity, because of course we know that active IBD is harmful to a pregnancy. And so and you're not using a steroid unless the IBD is active. So it's a little bit hard to sort out which causes which, but our priority with steroids should always be to use the lowest dose for the shortest amount of time possible. Here is PIANO data. So PIANO is the multi-center North American registry to look at pregnancy safety outcomes. And the PIANO study looked at pregnancy outcomes amongst mothers with IBD exposed to systemic steroids. And they found that there were not more cleft palate deformities or congenital malformations, but there was more preterm birth, low birth weight, and gestational diabetes. So again, the preterm birth and low birth weight are really tracking again with active disease, which makes sense if they're going on a steroid. And the gestational diabetes, as we know, diabetes and elevated blood sugars are a risk with steroid use. So safety of drug therapy, of course, these medications have been looked at in many different registries across the world, but this is in particular the PIANO data. So PIANO stands for Pregnancy and Neonatal Outcomes. And this is after fetal exposure to biologics. So this included a lot of anti-TNFs, some anti-integrin like vedolizumab, some anti-IL-12/23 like ustekinumab as well too. And they looked at patients on oral immunosuppressants like azathioprine or 6-MP, biologic medicines is the ones I've just mentioned, or the combination. And they found that there was no increase in congenital malformations, spontaneous abortions, preterm birth, low birth weight, or infections. But they found if there's active disease, there was a higher risk of miscarriage. But they also looked at development in children. They followed kids out and they found that there was no impact of drug exposure on baby's development. So really underlying the safety of staying on effective medications to maintain remission. Biologics are transported by the placenta. Of course, biologics are antibodies, and the placenta is designed to transport antibodies to the baby because you want to give the baby moms antibodies to provide them with immunity after birth. So infliximab and adalimumab are found to actually have higher concentrations in infants at birth and in cord blood than the mom. And so that's because we can see after about 20 weeks, so oops, sometime in the second trimester there, I made my thing go back. Uh, Sorry. Sometime after the second trimester, the placenta is actively transporting drug to the baby because it wants baby to get these antibodies. And so baby will be born with a drug level, but that's also to say there's not a whole lot of exposure in the first trimester when most of the organ formation is going on, but there's more exposure in the second and third trimester when the placenta is really trying to get antibody to baby. Sorry. So in terms of dosing, I get a lot of questions about, well, what do we do? Infliximab is weight-based dosing, right? It's 5 milligrams per kilogram. So do we keep giving them more as their weight is increasing over pregnancy, or do we hold their dose stable? What do we do with their dose? And so this study looked at the infliximab drug levels during pregnancy and found that they actually naturally rise over the trimester. So you can actually keep the infliximab dose at the pre-pregnancy dosing. You don't have to keep changing it as their weight changes week by week. Adalimumab levels stay pretty stable throughout pregnancy. So even though weight is changing, as you know, dosing for adalimumab is not weight-based, and that kind of bears out through pregnancy that we're able to maintain stable drug levels on the same dosing. Women are nervous about where to inject the adalimumab. They can inject in their stomach still. That needle is not that long. It's definitely not going to get into the uterus. But obviously the shot can be injected anywhere. It's a sub-Q shot. It can be anywhere they can reach. So they certainly can avoid the stomach if that's more comfortable for them. Um, More data about anti-TNF therapy. This is a Danish cohort study. There used to be older European guidelines saying to stop therapy and not continue it during the third trimester. That now has changed. Now, internationally, the agreement is to continue therapy throughout pregnancy, including the third trimester, to maintain remission. And this is just data that this is based on, that. That it is safe to be on the anti-TNF during the third trimester. It is not associated with a low birth weight or preterm birth. This is further data from Europe. This is the European Conceive study, and it looked at outcomes in babies exposed to vedolizumab in utero, anti-TNF in utero, or control IBD patients that were on neither an anti-TNF or vedolizumab. And they looked at, what age were babies born at, gestational age. They looked at their APGAR scores at birth. They looked at their median birth weight. They looked at how many were small for gestational age, congenital abnormalities and infections. And you can really see that there was not a significant difference between any of the groups. There's really no signal that these medications were increasing risk of any of these outcomes. This is the JETED cohort, which is a French cohort, again, looking at ustekinumab and vedolizumab safety, and found that the most frequent outcome was an uncomplicated pregnancy with these medications. So in the piano study, they had a more recent publication looking specifically at ustekinumab and vedolizumab safety. So this was over 1,000 completed pregnancies. They had 47 on ustekinumab, 66 on vedolizumab, 430 without exposure. And again, they found these medications were safe. No preterm birth, spontaneous abortion, small for gestational age infants, intrauterine growth restriction. So we found that, again, really showing us that these medications are safe to continue. Drug levels for vedolizumab and ustekinumab. Again, these are not weight-based dosed medications. So vedolizumab levels do fall about 30% over pregnancy due to increasing rate. Ustekinumab levels stay stable. Placental transfer of ustekinumab is a little bit higher than vedolizumab. Vedolizumab is undetectable in the infant serum earlier than ustekinumab. About 88% of babies don't have vedolizumab by 15 weeks. And 20 infants with no drug levels received rota, and there were no adverse reactions. We're going to talk a little bit more about rotavirus vaccine in the coming slides. So now turning to our more our newer medications, risankizumab. So the piano registry hasn't published a whole lot on this yet. Of course, risankizumab has been out for other conditions like psoriasis before it was approved for inflammatory bowel diseases. The piano registry has included 3 patients on risankizumab. Interestingly, there is a mutation in part of the antibody. So the FC fragment, and if an antibody is kind of shaped like a Y, that stem part of the Y, the FC fragment has a mutation in risankizumab, and that mutation does not allow the drug to bind to the antibody transporter in the placenta as well. So actually risankizumab is transferred across the placenta less efficiently than other biologics. So the infant blood levels of risankizumab were actually lower than for other biologics because it doesn't fit the transporter quite as well. So this just is looking at that. This is these 3 patients looking at what their drug levels were. And you can see, unlike other biologics, the umbilical cord blood levels were much lower. The parent, this mom was at 28.6, baby was at 5.96, patient 2, mom was at 9, the infant's cord blood was at 3. So the infants have a lot less drug on board. Tofacitinib. So the JAK inhibitors, such as tofacitinib, upadacitinib, do not have established safety in pregnancy at this time. So at this point, our recommendation is to avoid these medications in pregnancy. That's not to say that these medications should be avoided in all women that could potentially bear children. I don't do that. That's not my practice. I tell women when I'm of any age or plans that is the case, that pregnancy safety is not established at this point. We don't have enough data to tell them they can safely continue it. So if they are planning to become pregnant, that's something that we should discuss at that time, because obviously data is always changing. We're always learning new things. And that the patient and I will need to assess risks and benefits at that time. So I try to tell them, and I try to do that for any medication that I'm starting in any patient that can bear children, that I try to review with them what the pregnancy safety is, and just to put it out that if they are planning it at some point in the future, that is something that we should discuss. So for tofacitinib safety and pregnancy, this is sort of the people that were in the clinical trials that were not, were instructed not to become pregnant, but did anyway, and what happened to them on tofacitinib. And what happened to them was that for the most part, they were okay. The cord plasma concentration was 74% of the maternal concentration, but there are unknown risks in breast milk as well. So interestingly, for the small molecules like tofacitinib or upadacitinib, they don't require that transporter in the placenta to be transferred to baby. So there is exposure in the first trimester when the organs are being formed. So they are a little bit different in that way. And that's why we really need more data to establish safety. Upadacitinib safety in pregnancy. So one of the reasons that concern has been raised, besides the fact that there is exposure in the first trimester, is that in animal studies there was teratogenicity, or there was evidence of birth defects at a dose that's equivalent to the human dose. So a lot of times you'll hear in animal studies that, oh, there was a birth defect, but it was at 200 times the human dose, or it was some amount that's much greater than what we use. In the studies for upadacitinib, it was about the equivalent dose, so it does give us more pause. However, thus far, when they have looked at all patients on all indications, recall that upadacitinib is approved for many different things: inflammatory arthritis, as well as inflammatory bowel disease, as well as atopic dermatitis. So there's many people that are on upadacitinib for many other reasons. And when all patients who are on upadacitinib for any reason were looked at, they had similar outcomes to the baseline risks of patients with chronic immune conditions. So they saw that, about over 50% of them had successful pregnancies. Some of them, had miscarriage, and there's elective termination by some patients who were uncomfortable with the risk profile. So this is a developing story. So at this point, we would not recommend continuing the medication during pregnancy. Ozanimod. So ozanimod is also a small molecule, and again is also not recommended to be continued in pregnancy at this time. This is the limited data that we have, again, from the clinical trials in patients that happened to become pregnant. These are very small numbers of patients, and there were a number of them that had live birth without any birth defects. However, it's not enough information at this point to recommend continuing it during pregnancy. So I treat these S1P receptor modulators very similarly to the JAK inhibitors, and that if I'm prescribing it for a woman who can bear children, I do tell them there's not enough data, to recommend pregnancy on these medications, and it's something we will need to review if that is something that they want to do in the short term. Mode of delivery. So essentially, IBD patients can undergo a vaginal delivery if that's what their OB feels is best, if they don't have active perianal disease, if they have not previously had severe perianal disease, or if they don't have a J pouch. So if they've had a prior rectovaginal fistula, that would be an indication for elective C-section. Rectovaginal fistulas, even if repaired, could open again, so C-section is recommended. If there is an active perianal disease going on, C-section is recommended. If there is nothing going on when they have that group B strep culture at 35 weeks, a vaginal delivery would be fine. For ileal pouch, the patients with an ileal pouch really depend on their anal sphincter functioning well to maintain continence and maintain a good quality of life and a number of bowel movements. And so it is high risk for them to have a vaginal delivery and risk any injury to that anal sphincter, because it's really going to severely affect their quality of life. So the safest, most conservative thing is to recommend C-section and let the colorectal surgeon know, so that they are available or can be available if needed during the C-section. So detection of biologics in breast milk. So the amount of biologic in breast milk is very, very low. It's barely detectable, and it's not thought to be of consequence. So it's safe for patients on biologics to breastfeed. They can do that. And so and when they've been looked at, there's no difference in growth, milestone achievements, or infection rates compared to breastfed babies who are not exposed to biologics. What about vaccine response? So the concern was, well, okay, fine, we're not seeing major sort of anatomic birth defects, but how is in utero exposure to biologics affecting babies' immune system development? And how do we measure that? Well, one of the ways is that babies get a lot of vaccines, and are they able to respond effectively to their vaccines? And the answer was yes. In infants that were exposed to biologics, they were able to mount an appropriate vaccine response. So that's kind of a surrogate for the fact that their immune systems work. We didn't blunt the development of their immune system. So this is, again, newer information that will be in these upcoming consensus guidelines for preconception counseling and pregnancy. Rotavirus vaccine. So rotavirus vaccine is the one live vaccine that infants receive. The first dose is at 2 months. It's an oral vaccine. And previously, we've told patients, okay, tell your pediatrician that your baby is biologic exposed and they cannot get the rotavirus vaccine. However, that has now changed. There was a prospective cohort study of biologic exposed infants that showed safety of the rotavirus vaccine on schedule. So meaning they can get it their 2-month visit. We used to say, oh, wait till 6 months, because at 6 months, the biologic level is nothing in all the infants. So to be on the safe side, do that. But now we say, you know what, you don't have to wait till 6 months, you can have it on schedule. So patients that were maintained on infliximab, adalimumab, ustekinumab, vedolizumab trimester through the 3rd trimester were studied. Their infants were given rotavirus vaccine at 2 months when they're expected to still have biologic on board, and they did fine. They did not have significant differences in lymphocyte subsets, immunoglobulin levels, or their mitogen responses. So at this point, we're saying baby can get all their vaccines on schedule, and we expect them to respond appropriately. So to conclude out this pregnancy portion before we switch gears to elderly, is that fertility may be decreased if patients have active inflammation or they've had a prior pelvic surgery. It's really of very key importance that patients have a stable remission before conception and that they maintain remission during that pregnancy on a medication that we know works for them and is safe for them. Most IBD most IBD medications can be safely continued during pregnancy, with the exception of methotrexate, which needs to be stopped well in advance, tofacitinib, upadacitinib, ozanimod, or etrasimod, the small molecules, essentially. Consider C-section if there's active perianal disease or in J-pouch patients. And also, we didn't really touch on this because it's kind of a whole nother talk, but there are high rates of sexual dysfunction in IBD patients. That is an area that certainly needs more study and attention and referral for our patients as well. With that, we're going to move on a little bit and switch gears to talk a little bit about a different special population, the elderly. So IBD in the elderly is an interesting topic in that there's what's called compounding prevalence, in that we have more younger onset IBD, and those people eventually become elderly. And then we also have more patients that are getting IBD when they're elderly. So from those, we have those two sources that are kind of combining to increase how many elderly IBD patients we have, and we're better at taking care of patients overall. So elderly IBD patients now represent about a quarter to a third of the IBD population. We used to say, oh, it's a disease of the young, old people don't have it, but the young people become the older people. And elderly onset patients are about 10 to 20% of new IBD diagnoses. So it's definitely something that should still be on our minds. When we're seeing an elderly patient, we should still be looking for IBD. We should still be keeping an open mind that that might be what it is, to make sure that they get the appropriate diagnosis and treatment. So, elderly IBD patients are not the same as the young, and that's for a lot of different reasons. When we're thinking about their diagnosis, the range of possibilities of what it could be is much larger, right? Cancers are much higher on our list. They're often on a lot of other medications that may have side effects. They may have had other prior surgeries or prior conditions involving their bowel. So we have a lot more factors to take into account with someone who's in their 70s and someone who's 17 about what our possible options are. The clinical presentations might be more subtle. They might not have the same symptoms as the younger patients, but they can have a disease course that's as severe as the younger set. It might not just be this mild disease course. And there does seem to be a difference in the people that are newly diagnosed IBD patients when they are in their older years versus those that were diagnosed with IBD when they're younger and have just had the disease for 50 years and now are older. Those seem to be different patient populations that act differently. When we're thinking about treatment for these patients, we have to take into account some other differences as well. There's this immunosenescence idea that the immune system is different as we age and it changes also. And so some of the things that we know to be true in younger patients about immunogenicity and forming anti-drug antibodies and drug levels may not be quite the same because these patients' immune systems might be acting differently. There's also frailty, we also need to take into account. We also need to take into account, how, what is this patient's functional status? What's their mobility? And when we're thinking about it. I think top of mind when we're thinking about medication choice is there other comorbidities? What are the medical conditions do they have? And how does that affect the risk benefit profile of being on certain medications or recommending surgeries? So I think it's really important to take a careful history. We're not used to talking about that. I saw a 76-year-old earlier this week, and I'm not used to talking about the carotid arteries and what percentage they're blocked and what the plan is for them. But it can be highly relevant to what their plan overall is and what their options are. They also have a higher risk of treatment complications. We do see that the older patients are the ones that tend to get more of the infection complications, or like in the case of the tofacitinib data, those are the ones that had the blood clot risk in the RA oral surveillance data. So I think there's a lot of other factors to take into account when we're thinking both about what the diagnosis is and what the best and safest treatment is for these patients. So there's a really poor representation of the elderly in our drug trials. When there was a systematic review of older adult inclusion in randomized controlled trials, they were less than 1% of the participants were over 65. So a lot of times the drug trials actually exclude patients over a certain age, or they exclude other conditions which older patients tend to have, or they exclude any history of a prior cancer. So all these things are ways that our older patients get excluded from clinical trials. So we don't have as much information about whether these factors that could potentially affect their response, such as the aging immune system, their other medications, things like that. We don't really have a lot of good data and how that comes to bear on the medications. So for non-immunosuppressive medication trials, you can see out of over 300, there were 18 elderly or non-biologic immunosuppression trials. There were 17. So the numbers of patients that are over 65 in the drug level in the drug trials are really small. So we just don't have a lot of good information. That being said, I think perhaps because of this and perhaps because of fear of risks, older patients with IBD are less likely to be on biologics. 2% of patients in ulcerative colitis and 6% in Crohn's disease at 5 years post-diagnosis were on them, as compared with 7% and 20% in the adult population. So quite a bit less. In the Target IBD multicenter study, older patients with IBD were prescribed more aminosalicylates and less anti-TNFs. So I think there's this real reluctance, to give them advanced therapies. And the question is, are we really best serving them by doing this? By withholding our best therapies for those that really need it. Everything comes with a risk and benefit, and there's clearly risks to undertreating disease, as well as risks to the medication that we really need to take into account. So I think some of the key points as we think about medical management in the elderly patients is steroids are not a long-term therapy. Unfortunately, this is true in all patient populations, even in the elderly, and especially in the elderly who might also already have some bone density loss, who may be more prone to fractures already, who might already have diabetes. That steroids, we shouldn't say, oh, we don't have a lot of data on the biologic, so I'm not going to give you that biologic. I'm just going to keep you on a steroid. We know that steroids are our most dangerous medication, and that's definitely the case for the elderly as well, too. So we should not keep them on steroids instead of trying an advanced therapy. The principles of selection of optimal medical therapy in elderly patients really should be similar to the general population. Just because of age alone, we shouldn't say, oh no, we can't give you that medication. You're too old for it. We really need to think about risks benefits as we would in anyone. Safety is obviously a consideration as it was with anyone, but and there's limited data, but the newer biologics, we know anti-IL-23 therapy is very low in infection risk. We know anti-integrin therapy is low in infection risk. So we have safe biologics that are low in infection risk. Immunizations are of key importance in this population, really making sure that they're up to date with all immunizations, with their pneumococcal vaccine, with their Shingrix vaccine, with their RSV vaccine, really making sure that we've done that beforehand and we've really provided all the safety that we can is important. Biological age is more relevant than chronological age as well, too. Not all 75-year-olds are the same and have the same risk factors, so they really need to be seen as individuals with their own set of risks. And the desired outcome should be individualized. You really need to talk with a patient about their goals and the risks and benefits for them before you decide on a medical management plan. And so with that, I will finish up so that we can leave a little time for questions before the lunch break.